Good morning, everyone. I know people are filtering in. Take a seat when you're able to. I am really thrilled about both of our speakers here today to talk about shaping new horizons and approaching weight management in people living with HIV. We have national experts in the medical and surgical management of weight and here to talk about how we can apply those skills to people living with HIV. So very excited to introduce first Dr. Diana Thiara. She is an assistant professor of medicine at UCSF DOM, and is the medical director of the weight management program at UCSF. And we'll have Diana take a few minutes of questions and then turn the floor over to Dr. Jonathan Carter. John is a professor of surgery, also at UCSF, and a director of the fellowship, am I going to say this right? Advanced GI Minimally Invasive Bariatric Surgery Fellowship. And so it'll be really phenomenal to have insights, both medical and surgical, that we can apply to our patients. So without further ado, let's welcome Dr. Thiara.
Thanks for having me. I am honored to be asked to come back again this year. I gave a similar talk last year, but I started my medical career doing research in HIV and cardiometabolic health at the NIH. So this is a very special community, and I'm really happy to be able to give this talk today. Am I supposed to do with the mouse or? Okay. There we go. Okay. So just to start, I'd like to give a bit of a lay of the land on how we think about treating obesity in 2024. So at the base of our treatment pyramid, we have primary care providers, where you all would fall into this category. And it's really our primary care providers who are at the front line of screening patients for overweight or obesity. And primary care providers really should feel empowered to be able to discuss weight with their patients if their patients are open to that conversation, and start the framework for lifestyle change work through nutrition and activity, and also feel empowered to think about starting medications if it's something that's within your comfort level. As BMI increases and cardiometabolic and mechanical diseases of obesity increase as well, that's when you can think about escalating the treatment approach. So you can think about referring to specialty weight management programs, where we talk a lot about lifestyle change, obesity medications, and meal replacement. And then above a BMI of 30 with a metabolic disease, or a BMI greater than or equal to 35, you can also consider a referral to bariatric surgery. The key here, though, is it's really up to the patient. So while our treatment options can escalate based on BMI and metabolic disease escalation, the conversation you all need to have with your patient is what treatment they're interested in. And remember that that decision with the patient isn't static. So while you can have those conversations early on, you really should be approaching it serially with your patients in a way that's comfortable for them, and ultimately know what these options are, but respect your patient's decision on how they want to proceed with treatment in this space. So before we get into the nitty-gritty, let's just zoom out a little bit and think about what is our goal in treating obesity. Our goal is to improve health, not to focus on size conformity. We should not assume that someone with excess weight is inherently unhealthy. That is just simply not true. And we know that even with modest amounts of weight loss, we can see improvements in health. So we know that at about 5% body weight loss, we can start to see clinically meaningful changes in things like A1C and blood pressure. But once we get above that 10 to 15% body weight loss is when we actually can start to see signs of remission of certain disease states and reduction in medication usages. Above that 20 to 25% is when you can really get patients off of a lot of their cardiometabolic diseases and start to see improvements in things like arthritis, mechanical diseases, as well as quality of life. So the key here is to not fixate on BMI targets for treatment. It can be incredibly daunting to tell a patient who has a BMI of 35 or 40 that they need to get to a normal weight to have healthy cardiometabolic functioning. And we simply know that that's just not true anymore. Even with modest amounts of percentage changes in their weight, people can have longer, healthier happier years of their life. And the last bit is treating obesity really requires a chronic disease management approach. Just like any other cardiometabolic disease, we know that obesity is a disease that has a long-term chronic nature. And so while there may be times where someone is doing really well, there are also times where they may have some relapse in their disease state. So you need to have a long-term approach for these patients, not only to see improvements in morbidity and mortality, but also to help them with their quality of life and improvement in disease state for the long term. Okay, so I'm not going to spend a lot of time on lifestyle change because I think medications are what are on the top of people's minds right now, but it's really important to know that lifestyle change is really, really key for the long-term treatment of obesity. We know that taking a medication will not teach someone how to eat healthier foods or exercise more. And that is really key for helping people preserve healthy body compositions and to have optimal success with these medications. So while medications are an option that we will talk about and that we should use, they're not in replacement or substitution for the lifestyle change, which really is the biggest piece of the puzzle. The other part that we'll get to more with the data and sort of real life usage is people who are engaged in healthier lifestyles, specifically with nutrition, will have better tolerance of the medication, as well as lower attrition rates. So really remembering to continue that nutrition and exercise counseling is key as you're thinking about escalating treatment options with medications or with surgery as well. So in terms of medications for weight loss, there are currently 6 FDA-approved medications for long-term use. So we have orlistat, which is a lipase inhibitor, has about 3% body weight loss. So that's not clinically meaningful, and it's not something we use a ton of, but it is something in our armamentarium. We have Contrave, which is a combination of bupropion and naltrexone. We see about 5 to 8% body weight loss at 1 year with maintenance of around 3 to 5%. So again, not great long-term weight loss to show clinically meaningful changes for patients. We have Saxenda, which was the first GLP-1 receptor agonist FDA approved for weight loss, and it was approved in around 2013, showing around 5 to 10% body weight loss at year 1 and 6% at year 2. And then we have Qsymia, which is an oral pill combination of phentermine and topiramate, which is excellent weight loss at year 1 of around 9 to 14% and maintenance of around 10% at 2 years. Qsymia is a great drug for patients who don't have sort of contraindications to use. There wasn't great uptake when it was FDA approved in 2014 because there was some bungling of what happened with the FDA approval that sort of just didn't put it on the PCP's radar, but it is the drug of choice for the study coordinators for things like SELECT for STEP trial when they had to come off of Wegovy. So it is a good option for patients who can't tolerate Wegovy or who, for some reason, they just can't take the GLPs. And then we have the 2 newer drugs that we're going to focus on today, which is Wegovy, which is known as semaglutide, and this is a weekly injectable GLP that shows 12.5% body weight loss at year 1 and maintenance of that weight loss at year 2. And then the last is the newest medication, Zepbound, which is known as tirzepatide, which shows around 18% at year 1 and 26% or so at 88 weeks. So as we think about when to start medications, there are clear FDA indications for who you can prescribe these medications to. And it's indicated for individuals with a BMI greater than or equal to 30, or for individuals with a BMI greater than or equal to 27 with a weight-related comorbidity. And remember, these are meant to be used as adjunctive tools to lifestyle change. So it's not just a thing you put a patient on and see you in 6 months. It's really a medication that requires a comprehensive approach for patients to be successful, and we'll go through some of that data. These medications are meant to be used for the long term, and for years we said there was no reduction in morbidity and mortality associated with anti-obesity medications, but now we know with the SELECT trial that semaglutide has a 20% MACE reduction, and these comorbidity long-term data are just going to come out more and more over the next 5 years. So we went through a lot of this last year. So I'm going to breeze through some of the basics of GLP-1s. This is just a little bit of a refresher for those who are new or who haven't been thinking about this as much. So why are GLPs so effective for long-term weight loss? It's because they have both peripheral and central actions. So in terms of the central actions, the reason our bodies evolved to have hunger signals were based on these neurons in our hypothalamus that communicate with our peripheral hormones. So our satiety center was based in the hypothalamus. And historically, medications for weight loss all worked in the brain, but we eat for reasons that have nothing to do with our hunger signals. We eat for a lot of different reasons. And so those medications didn't have as much long-term efficacy. But GLPs do act in the hypothalamus to promote satiety via the POMC-CART neurons. And that's why we have patients describe that the food noise is gone. I just don't have those cravings for food anymore. That's actual central action in the hypothalamus that's changing people's reactions to food and cravings. And then it's really these peripheral actions that make patients have more weight loss, but then keep it off in the long term. So they act on the stomach to decrease gastric emptying. They act via the pancreas to increase insulin secretion, and then they act via the liver to improve insulin sensitivity. And it's really that trifecta of peripheral actions that helps promote weight loss and improve metabolism. So these side effects, I'm not going to exactly talk about them in a boring way. I'm going to talk about them more and how we can mitigate them. So the most common side effect associated with GLP-1s is nausea. Why? Because it delays gastric emptying. So food is just sitting in your patient's stomach for a longer amount of time. It's not gastroparesis. That's not a real risk. It's literally the medication has the GLP receptors are at the stomach pylorus. They prevent that from opening, so food sits there longer. What types of food make you feel more sick? High fat, highly fried foods that are big in portions. So for patients who come to you and they say, I have nausea, it's not getting better over time, some days it's worse, or sometimes I even throw up, the key question to ask is, okay, well, have you noticed any association with certain foods and those symptoms being worse? Is it worse when you eat out? Is it worse if you're having things like ice cream or pizza or French fries or things like that? And find the days you have smaller portions eating at home? Oftentimes the answer is yes. And for some patients who have a little bit harder time teasing that out, we'll give a very specific diet for just a couple of days for patients to try to adhere to. For our patients who are a little more highly resourced, we'll recommend food delivery services just for a week to see if that tolerability issue with the drug is really something biologic that the patient will not get over, or if it's more of a dietary related issue. One thing that people don't think about as much is, adult humans are not meant to consume a lot of dairy. So high dairy products, things like ice cream, milkshakes, any non-fermented dairy oftentimes makes people feel worse. So we really try to mitigate the gastric side effects through dietary changes. We also won't necessarily dose escalate by the way the pharmaceutical company recommends. We'll give people time to let them feel good at a steady state before we increase. The other big side effects that we see more chronically are lower GI, so things like constipation or diarrhea. And what we notice here is even people who have really optimized fiber consumption through dietary sources, adding something like Metamucil or psyllium husk or whatever, adding a fiber supplement can also really help those patients a lot. So before we put on medications to treat side effects, which is not our goal, we are not trying to cause problems and then treat those problems. We want people to be able to engage in lifestyle change, to be able to tolerate these drugs in the long run. The other side effects you might see are things like dizziness, headache, fatigue. Those oftentimes are related either to dehydration. So people oftentimes have reduced hunger signaling and they also have reduced thirst signaling. So you want to make sure people are drinking enough. And sometimes those are also signs of hypoglycemia. So in your patient who's like, I never ate breakfast and I'm definitely not doing it now, they actually may have some AM related hypoglycemia that's leading to those issues or nausea and things like that. So again, a time to do a diet recall to make sure people are eating consistently throughout the day. And then the rare but serious side effects are pancreatitis, cholecystitis, which were seen in less than 1% of the study population, as well as suicidal ideation. The suicidal ideation is sort of a big question mark that came up in the post-study reporting from patients. And there's been very mixed data. Some people say that there's less SI because people's mental health improves. And some studies are showing that there is SI. So we counsel patients we don't know. If your mood worsens or if people around you think your mood is worsened, you should let us know right away. So way more to come with the mental health implications. In terms of absolute contraindications, personal or family history of medullary thyroid cancer or MEN type 2, this is what gives this medication a black box warning. It was seen in rat studies. Rats are not the best thyroid surrogate for humans, so we've never seen this happen in humans. We haven't seen any progression of our patients developing thyroid cancer of any sort. But if we do have to screen for personal or family history of medullary thyroid cancer. The more and more we've done this, we've seen patients who've had nodules that have never been biopsied and things like that. So it's up to your clinical decision-making and talking to your colleagues around whether or not you want to get those nodules biopsied if they never have been. I tend to, if it's big enough to get a biopsy out of an abundance of caution. But I do think over the next few years, as more and more people are on these medications, we get more data. I think this worry and concern will go down. And then the last contraindication is pregnancy. So GLP-1s are not a teratogen, but they do increase risk of fetal loss through placental issues. So you really want to counsel your patients who are of reproductive age that because of the long half-life of these drugs, they should be coming off at least 2 months before attempting conception. And sort of the other side of the coin is we've seen a lot of patients accidentally get pregnant while on GLPs because of concerns of sort of decreased OCP absorption, as well as weight loss that increases fertility. And largely those pregnancies have been okay. But for our patients who are really actively trying to get pregnant and the risk of fetal loss is, concerning, we don't want to add more stress onto them and add another question mark of what they could have done differently. So counsel on the risks associated with pregnancy, but also for you all to know it happens and it's not a teratogen. So we discussed the results. In terms of dosing guidelines, Saxenda is a daily injection. You reach effective dose at 5 weeks. And Wegovy or semaglutide is a weekly injection, and you can reach effective dose at 5 months. I have a test pen if anyone wants to see it afterwards. But the key here is you dose escalate monthly. You don't have to dose escalate. So if someone is losing weight rapidly, or someone is still having low-level side effects, or they just don't want to, you really don't have to follow this monthly dose escalation. And what we do in our practice is every month we have a chat, whether it's a quick phone appointment or over my chart, and ask how much weight have you lost in the last month? How many times a day are you eating? And what are you doing for other exercise? And if there's any and obviously, how are you feeling? And if there's any red flags that your patients are not eating, that is a reason to not dose escalate. We do not want to accomplish weight loss because we've effectively induced an eating disorder. We want to achieve weight loss through healthful ways where people are fueling their bodies with protein and micronutrients and all of those things. So in terms of Wegovy, the seminal trial here are the STEP trials. This was published in 2021, so we're not going to go through it in depth, but just so you all remember what this study looked like, it was around 2,000 participants with with obesity. Diabetes was excluded, and individuals were randomized to semaglutide 2.4 versus placebo, and there was no run-in phase. So for most medication trials prior to semaglutide, there was a run-in phase where for 12 weeks, participants had to lose at least 5% of their body weight through lifestyle change before they could be randomized to drug or placebo. They did not do that for this medication. It lasted 68 weeks, and there was an intensive lifestyle component. So that's a key bit. When we see those great results for these studies, you have to remember that all of them had intensive lifestyle intervention where patients were monitoring their food intake, they were counseled on increasing physical activity, and they had monthly meetings with counselors to go through their lifestyle change work. And what we saw was that 15% body weight loss, but when you take out the placebo, it's closer to 12.5%. But what was more impactful and more sort of brand new in the weight loss space was that at 2 years, there was maintenance of all of that weight loss. And the other key study here was the step 1 extension that looked at weight maintenance after discontinuation. And not surprisingly, after stopping the drug, participants regained about 2/3 of their body weight back, and we would expect more over time. And why does that matter? Well, one, they're not going to have clinically meaningful weight loss anymore. So all of that hope of improving someone's morbidity and mortality risk with their weight loss, that's gone. But the other bit that I think is really important to understand is that with any form of weight loss, whether it's lifestyle change or surgery or medications, the human body loses fat, but it also loses muscle. And with that body composition change, it's actually more optimized. The fat to lean muscle mass ratio has gotten better. But when people regain weight, they're going to gain it mostly as fat, not as muscle. It's very hard to gain muscle. That's why bodybuilders are in the gym with these really intensive lifestyles. So when our patients regain weight, their body composition profile is actually worse than if they had done nothing at all. And why does that matter? Because more adiposity to lean muscle mass is going to be more prone to things like cardiometabolic disease. And there's also data showing that people who have had that body composition change that's favoring more adipose tissue are more likely to develop the obesity-related cancers. So it's not just a yo-yo. It's actually changes in body composition that's ultimately making someone more at risk for adverse health consequences. So it's really, really important to explain that to your patients. It's not just going back and forth. It's making your health potentially worse than if you had not done nothing in the first place. So the SELECT trial was the semaglutide effects on cardiovascular outcomes in people with overweight or obesity. And this was published in December of 2023. And so this was looking at how does semaglutide help individuals with overweight or obesity who have known cardiovascular disease. It excluded individuals with diabetes. This was a huge study. So 17,500 patients enrolled, half to semaglutide, half to placebo. It was around 70% male with a starting age of 61, which is very atypical. So almost all weight loss interventions skew female because of, the ills of society. But this study is skewed male because of the requirement for known CVD. And the duration was quite long, around 4 years on average. And we went through this last year, but again, I think this is a really seminal article that's really changing the landscape of obesity treatment. So we'll go through these results again. So box A was the primary cardiovascular composite endpoint, which was comprised of cardiovascular disease-related death, non-fatal MI, and non-fatal stroke. So they pooled those 3 events into primary composite endpoint. And what you see is this orange line here is semaglutide, the gray is placebo, and you can see a 20% risk reduction in that primary composite endpoint at 4 years. The key thing here, when you look at the sub-analyses in the appendix of the paper, so something no one's looking at, is that it's the non-fatal MI that's really driving that result. So the non-fatal MI risk reduction was closer to 30%. So that's what we're really seeing less of. There weren't many stroke-related events anyways, but there was reduction in that and some small reduction in the cardiovascular death as well. And the other interesting thing is that the weight loss these people had at 4 years was only 8.9%. So there are thoughts, one, that major weight loss isn't required to help improve MACE reduction, but also if you talk to the endocrine folks, there's thoughts that there's something with the GLP itself that's providing MACE reduction independent of weight loss. So it's really this result here that's made Wegovy such a powerful medication for individuals with excess body weight and known CVD. Box B is death from cardiovascular causes. And unfortunately, that confidence interval just crosses 1, so we can't say there's any statistical significance there. C is heart failure composite endpoints, which was categorized as admissions to the hospital for heart failure or an acute heart failure related appointment. And you can see, again, a risk reduction of around 18%. And then D is death from any cause. And what you can see is about a 19% risk reduction. So the newer studies, what's come out since last year? One is effect of semaglutide on kidney functions in individuals with overweight or obesity. This is an exploratory analysis of step 1 through 3. This is not a phase 3 study, which means this is not going to change what the FDA covers this drug for. And so what you can see here is that these were not patients with CKD. These were patients who largely had normal kidney function, but there was a small subset with microalbuminuria. And what we can see in both the semaglutide 1 and semaglutide 2.4 groups is that there was actually an improvement of albuminuria in both sets of groups, the microalbuminuria macro in both doses. Whereas in the placebo group, we actually see worsening in those metrics. So we are really encouraged to see that we can see improvements in albuminuria status in our patients. Again, these are not patients with CKD. And then not surprisingly, no change in eGFR, but if you look here, these are all people with normal kidney function. So this is one of those things that's interesting, but it's not necessarily massively practice changing. So just some key facts, Wegovy and Ozempic are both semaglutide, but they are technically not the same things in the eyes of the FDA or in the insurance companies. Wegovy goes up to semaglutide 2.4 milligrams and Ozempic only goes to 2. And Ozempic is FDA approved for use in individuals with diabetes and Wegovy is FDA approved for use in individuals with obesity. It's also, now FDA approved for individuals with known cardiovascular disease and a BMI greater than or equal to 27. So that's an entirely separate FDA indication now because of the SELECT trial. Wegovy is incredibly expensive and Medicare will not cover any medication for obesity if obesity alone is the indication. That is by law. There's no amount of prior authorizations or ChatGPT helping you. It is a law that the United States government has passed in the early 2000s. However, because of this secondary FDA indication now, Medicare will cover this drug for individuals with cardiovascular disease and a BMI greater than or equal to 27. What is each supplement counting as CVD? That's sort of a black box. We don't know. We kind of throw darts and hope it'll stick, but they're very, very strict on what they'll cover, and they require us to show proof of things like a cardiac catheterization showing a blockage or a surgical report for someone who's had a CABG. So it's very, very strict, but it is a new indication that Medicare will allow. Okay, so pivoting to Zepbound. Zepbound has all those lovely GLP effects, but then has this added GIP, which is an increased lipolysis and fatty acid synthesis. So Zepbound is not a GLP receptor agonist. Zepbound is a novel dual GIP-GLP receptor agonist. It's a totally separate class of drug. The SURMOUNT trial is the seminal trial for tirzepatide, and this data was published about 2 years ago, so we'll kind of breeze through it. But tirzepatide shows the largest amount of weight loss through any medical intervention ever. And what you can see here in this dark teal line is about 21% body weight loss at 68 weeks. And when you take out the placebo, that's around 18% on average. But what's even more amazing is that in over a third of patients, they had over 25% body weight loss. So over a third of patients are going to have greater than 25% body loss. Let that settle in. And when you look at subgroups, women who are under the age of 50 with BMIs over 35 are going to be more likely to be hyperresponders and on average lose closer to 30% of their body weight. So not everyone is going to need to be on the highest dose of tirzepatide. Not everyone should be losing that large amounts of weight. And so you really should be thinking about the nuances now that we have more tools in our toolbox on how to treat our patients based on their starting BMI and their other comorbidities. SURMOUNT-4 is a study that showed a little bit of the long-term data, but also what happens when you take patients off the drug. So patients were on There was a 36-week run-in, half continued to 88 weeks, and they showed around 25% body weight loss. And then the other half went to placebo. And in the placebo group, they regained a lot of their weight. And we would expect more of it to come back over time, just like we did with the STEP extension trial. In terms of the newer trials that have come out is Surmount OSA, which is a phase 3 trial, which means this data can be used for additional FDA coverage of the medication. And the inclusion criteria here was individuals with overweight BMI and moderate to severe OSA. So that's with AHI of at least 15 events per hour for moderate and over 30 for severe. Exclusion were people with diabetes and people with central or mixed sleep apnea, or individuals who are having surgery for OSA or obesity. There was around 230 patients. Half were randomized to either tirzepatide 10 or 15, and the other half to placebo, largely male and largely older than most of our studies. The average BMI was 39, and the average AHI event rate for this group before the study was 50. So these were people who largely had severe OSA to start. The study duration was 1 year, and there were 2 trial groups. One was individuals not on PAP, and one was people on PAP. And so what are the results here? Well, these red boxes, the primary endpoint was change in AHI. So there was a reduction of about 20 events per hour in the non-PAP group and down by 24 in the PAP group, which is pretty impressive. So this took individuals who were really, really severe into closer to the moderate category. But you also have to expect that some people went from moderate to no longer having sleep apnea if they were less than 20 to begin with. And you see a large reduction in percentage of AHI as well. And the percentage weight loss is interesting to note, which was a little lower, but around 16 to 17% at 1 year. And the other big tirzepatide study that's come out in the last year is the Synergy NASH, which is a phase 2 trial. And this is not necessarily focused on individuals with obesity, but this is focused on individuals who have stage F2 or F3 biopsy confirmed MASH. These people largely have obesity. So the average BMI is 36, over half identifies female, and over half have diabetes. And the duration was 1 year. And what we can see here, so box A is resolution of MASH with no worsening fibrosis. And you can see a stark difference between that tirzepatide 15 milligram group and placebo. And you can also see a dose-dependent change. So those in the highest group, the highest dose of tirzepatide were more likely to have resolution of MASH at 1 year. B is decrease of fibrosis by at least 1 with no worsening MASH. And here you can see there's not really a dose dependence. So more tirzepatide is not always better for the fibrosis bit, but there is a difference in the tirzepatide group versus placebo. And so we're hoping that the phase 3 trial will show similar results. And if that happens, then we can use tirzepatide in use for patients with MASH regardless of their weight status. So just some key facts. Again, study design, people were well motivated to do all the lifestyle change bit. Surmount 3 actually had a 12-week run-in phase, and those patients had about 3% additional body weight compared to the initial Surmount 1 that did not have the run-in phase. Again, 2 forms of this drug. Zepbound is for use in obesity management and Mounjaro is for diabetes. But these are really the exact same drugs. They both go up to 15 milligrams, and there's way more to come. So there's Surmount MMO, which is looking at CVD outcomes, and that will be done in 2027, and the renal outcomes will be done around then as well. So I'm running over time, but let me just go through this really quickly. So what do you do once your patients qualify and they want to do it? The SF health plan and Medicaid we're very lucky. They cover these drugs, but you will almost always will have to put in a prior auth. And so if anyone wants a template on that, just email me and I can share that, but they ask very specific questions and they almost always require proof through your notes that they've been engaged in lifestyle change work for at least 3 months. And then in your patient population, just quickly, there is one retrospective study of GLP usage in persons with HIV. It was done at UCSD. It shows some weight loss and improvement in BMI, but it's not a very good study design because only 37% of the patients that initially qualified had long-term data, and what they considered long-term data was 3-month follow-up from initiation. So whatever numbers they're reporting is not really a good evidence of what would actually happen to someone who's using this in the way it's meant to be used. So in terms of just elevated cardiometabolic risk, we know semaglutide has improvements in HFpEF and MI. And for CKD risk, hopefully some signs of improvements with albuminuria, but we can't exactly translate the research we have to people with known CKD. And with the increased risk of fatty liver disease, tirzepatide is showing really promising results in resolution of MASH. Sorry. Okay, so and on the horizon, this is a bit of a gold rush right now. So there's oral GLPs, there's other dual agonists that are coming about, there's triple receptor agonists that are coming out, there's all sorts of stuff. So while we're excited about what we have, we should be even more excited for what's to come. So I'm sorry we went a little bit over, but should we switch to John? Yeah, okay, so now we'll have Dr. Carter come talk about bariatric surgery.
So excited to come talk to you. I haven't been here at the General in a while, but I trained here, and this place is, I have a lot of love in my heart for the General. It's nice to see you all. Oddly, slide's not advancing. So give me a second to troubleshoot. And we'll give it another shot here. That's interesting. Well, I could just do it this way. Why not? And we'll share this one. Okay, we'll just do it in this mode. So why do we treat obesity? And you might ask, what is the effect of obesity on human longevity? And that question was asked in a study of people living in Britain. And this is the relationship of body mass index to all-cause mortality. And there's a characteristic J-shaped curve. The lowest all-cause mortality occurs at about a BMI of 25, and that's true for both men and women. And then in men, around 27 is when you reach an inflection point, and then as the BMI increases, all-cause mortality increases. In women, there's more of a flatter zone up to a BMI of about 30, and then at BMI 30, all-cause mortality in women starts to increase. And so the more obese a person, the more obesity a person has, the more risk that they have of dying from some cause. And what is it that actually kills patients with obesity? It's really two things. It's cancer and it's cardiovascular disease. And you can see the individual hazard ratios for both cancer and cardiovascular disease as the BMI increases. And so once you understand that, it really makes sense why we might want to put riskier or more intensive therapies for people with more severe disease. And that's why we typically offer surgery for people at the high end of disease. The current indications for surgery are people with a body mass index of 35 or higher, or if you have metabolic disease like diabetes, hypertension, hypercholesterolemia, sleep apnea, severe DJD, then we lower the cutoff down to a BMI of 30. And that's because these are precisely the patients who have so much more to lose in terms of life expectancy as a result of their obesity. So what are the operations that we do at UCSF? There's really two operations. The first is the gastric bypass, and this was an operation that was first invented in the 1950s, but it really became popular in the 1990s as laparoscopic techniques to perform the operation were perfected. And at that point in the late 90s, the safety profile of gastric bypass really increased dramatically. And it went from kind of a scary operation with a 2% mortality to a not so scary operation with like a mortality rate of maybe 2 out of 1,000, something like that, on par with gallbladder removal or hysterectomy. In the 2000s, though, a simpler operation called a sleeve gastrectomy was invented, and this is really simple. All you do is take a stapler and you remove about 80% of the volume of the stomach. You don't touch the small intestines at all. And this operation was shown to have almost as good a weight loss as the bypass operation. And so very quickly, the sleeve became popular. At UCSF, about 80% of our patients go for the sleeve. And across the country, it's about the same. Most patients do sleeve. So do you guys want to see how we do it? All right. So what I've done, this is a human, and what I've done is I've taken the short gastrics and mobilized the greater curve of the stomach. And then I put this calibration tube called a bougie, and the bougie is about the size of my thumb. It's 40 French. And we stick the tube down the esophagus into the stomach. You can kind of see that, you get a sense that there's a little bit of a tube over here. And what that does is that calibrates the size of my sleeve. And then I'm laparoscopic, so you can see I'm using these long, skinny instruments to manipulate tissue. The patient has about 5 or 6 laparoscopic port sites. The operation takes about an hour. In terms of complexity or sort of the level of stress I have going in the operation, it's about the same as like a lap chole. So it's very routine. I don't stress it that much. Patients almost always go home the next day. And so what I do is I take this stapler and I'm literally just stapling alongside this bougie. The bougie is 40 French diameter. There's some technical nuance here. The first one, I want to leave the patient's antrum because the antrum helps kind of emulsify the food and push it through the pylorus. We want to preserve that motor function. We really don't want to affect the antral function. We really just want to affect the stomach's ability to act as a reservoir. Here at the crow's foot or the stomach incisure, I want to make sure my sleeve is not too tight. So, I'm visually estimating about 2 centimeters here, and I'm a little bit off the bougie and firing my stapler up. Each staple load is 60 millimeters long, and it usually takes me 5 or 6 loads to go up and divide the stomach. Here I've divided a few more, and we're up along the GE junction. You can see there's a fat pad that sits above the GE junction. We call that the frontoesophageal fat pad. So that's one of my landmarks. I stay just off the fat pad and my staple line goes off. You can see this blue cloth. This is it's basically like Vicryl mesh. It looks like cloth, but it dissolves after 30 days. And what that does is it just more evenly distributes the pressure from the staples, and that reduces staple line bleeding. So we got our bleed rates down to about 0.5% with this. And here I am finishing off the last load up at the GE junction. And that's my sleeve. So it's a really simple idea. Now we do what we call a gastropexy, which is where we'll suture the sleeve staple line to the omentum, the gastrocolic omentum that we divided. And we do that just to pull the staple line laterally. And also when the patient stands up, it pulls their stomach down. And that keeps that sleeve in kind of a nice straight configuration. So it doesn't have a weird twist or any sort of blockage. So that's the operation. So when you refer a patient, you don't have to be scared for them. I mean, it's a very routine thing. It's kind of like referring a patient for gallbladder surgery. You probably wouldn't hesitate to make that referral. And similarly, I think our outcomes with sleeve are actually better than with gallbladder surgery if you look at all comers. So how do we do with weight loss? And this is a typical curve. I love this study because it shows each individual patient. So this was a study of gastric bypass patients that were followed over 12 years. And at 1 to 2 years is when you get the most weight loss. With bypass, patients lose about 35% of their total body weight on average, which is dramatic. In comparison to some of the newer medicines, with semaglutide, it's about 15%, so that would be about here. With tirzepatide, it's about 20%. Although that's a little bit of a false comparison because the medical trials, the patients start with much lower BMIs than the surgical trials. So we probably shouldn't be comparing percentage weight loss, medicine versus surgery, one-on-one. If you had a cohort with much higher BMIs, similar to a surgical cohort, and looked at their medicine outcomes, it'd probably be a little bit less in terms of body weight percentage loss. At 6 years, you can see there's a little bit of weight regain, and then patients typically plateau out to 12 years. So you really get a dramatic weight loss. Now, look at the heterogeneity. You have some patients who really rock it out, lose 50, 60% of their weight loss. Those patients can get down to a normal body mass index of 25, and we see those patients. And we see those patients long-term that maintain that excellent weight loss. But we also have patients who are poor responders or non-responders who maybe only lose 10 or 10, 15% of their weight loss up front. And then as time goes on, it creeps back up, some even to baseline. So we see a lot of individual variability. Well, how do the operations work? This was a paper I wrote a couple years ago. And both sleeve and bypass induce very potent changes in hormonal secretion. Some of the hormones you recognize. There's a marked increase in GLP-1 that occurs after meals in response to these operations. There's a marked increase in GIP. And that's exactly how tirzepatide and semaglutide are working, acting on GLP-1 and or GIP. But there's also a decrease in ghrelin. There's an increase in peptide YY. There's an increase in primary bile acids that can be found in the bloodstream after meals. There's alterations in the colonic microbiome. And all these effects combine together to result in the really powerful weight loss that we see in our patients. These are the primary mechanisms. In the old days, we talked about restriction and malabsorption. And there is some element of restriction. When we sleeve a stomach, you physically can't hold that much food. So you can't eat very big of a meal in one setting. But that's not the dominant mechanism. The malabsorption is really not a mechanism at all. If you actually look at the feces of a patient who's had these surgeries and you look for undigested fat or protein, you won't really find very much. So none of these operations produce much calorie malabsorption. So what are the endpoints and why do we want to promote these operations for our patients? It's because we see a really dramatic improvement in metabolic disease outcomes and mortality. So if you look at coronary disease, there's about a 40% reduction in coronary disease when we do bariatric surgery. When you look at nephropathy, there's about a 60% risk reduction in nephropathy. When you look at strokes, now strokes are less common, so the cumulative incidence curves are less, but again, we see about a 33% reduction in the risk of our patients having a stroke. If you look at heart failure, there's a marked improvement. There's a 60% reduction in heart failure in favor of surgery. If you look at cancer, it's interesting. When a patient with obesity comes into your clinic, you may not think, oh my goodness, this is a carcinogenic situation and we should do something about the obesity to reduce their risk of cancer. But indeed, that's one of the most powerful reasons to treat obesity. And we know when we operate and perform metabolic surgery, we get about a 40% reduction in cancer incidence, all cause. And if you add up all of those together, we see a marked reduction in all cause mortality, about a 40% reduction in all cause mortality. So when someone walks into your clinic and their BMI is 40 or 45, you need to look at them and think to yourself, wow, they're probably going to lose 8 to 10 years of life expectancy by virtue of their obesity. And if I can get that patient treated, I can get them some of those years back, maybe even the majority of those years back. But there's a price with everything, and that's the price of complication. Here's the risks of surgical complications with bypass and sleeve. I think what surgeons have done, we've done a really good job of refining these operations. It's very cookie cutter. process. And we've been able to get these complication rates really, really low. Again, kind of on par with a hysterectomy or a lap chole. The one downside of the sleeve is GERD. About a third of our patients develop pretty severe GERD down the road, and they frequently require daily maintenance PPI. So let's talk about people living with HIV. It's not uncommon. I'll be referred a patient who has HIV for consideration. And there's a lot of theoretical considerations about the pharmacology of patients who are dependent on antiretroviral therapies and are interested in bariatric surgery. Some of the pills that patients have to take are great big horse pills. And that's important because if you do a bypass, the outflow of the gastric pouch is pretty small. I could maybe just get my pinky through it. So if you think about, as a patient going to be able to get a pill through this tight little anastomosis, it can be an issue. Some antiretroviral therapies, as you all are well aware, require an acidic environment in order to be absorbed. And this little gastric pouch can't make acid very well. There are some ARTs that are absorbed predominantly in the duodenum, and with gastric bypass, we have bypassed the duodenum, so the pill would never see the duodenum. The INSTIs can actually chelate with calcium and magnesium, and that's important to know because when we do bariatric surgery, we put the patients on supplemental calcium. So how do we do that? We have to separate the dosing. You need to take your calcium at this point in time and take your INSTI at a different point in time. Don't take them together. And then there's some that don't absorb very well and we think require the full mucosa of the entire GI tract. So all of those concerns, if you think about it, they're kind of mostly issues with bypass patients and less so with sleeves. And so when I see a person with HIV who comes into my clinic, I generally am thinking sleeve to bypass a lot of those issues. But if you look in the literature, there are some case series, and you might ask, well, how do patients do, patients with HIV who have bariatric surgery? And by and large, the message is they do really, really well. We went back and did a review of all the patients at UCSF that we could find that had HIV and had bariatric surgery, and there were 18 that we could find. There were 7 bypasses and 11 sleeves. When we looked at their HIV outcomes, they generally did great. The CD4 counts didn't change at all before and after surgery. When we looked at viral suppression, all patients maintained complete undetectable virus, except we had one patient, and it was a woman who had a sleeve. She had a lower CD4 count going into surgery. I think it was 250, 260, something like that. She had a little blip in her viral load post-op. We don't know why. She did have a change in her regimen, but it was not a significant change. There was no documented viral resistance. She didn't have any documented history of non-adherence to medicines. But what was interesting is she had a little blip and then she fell out of care. And so we wondered if maybe adherence was an issue in her. But if you look at everyone else here, this is each patient, and you can see what their preoperative ART regimen was. And in the majority of cases, we didn't change it afterwards. And in the few that we changed, it was done mostly by you all, their HIV providers. And it was either because of concern about the acidic environment or just the physical size of the pills. That's usually what prompted the change. Here was a study in France, which you can pull if you like. Again, a case series of 10 patients. Again, no loss of viral control, no change in CD4 counts. What was great about this study, they actually looked at the plasma concentration of their ART regimen, and they documented that there was no issues with absorption of the drug. So they documented adequate plasma concentrations throughout. And that's been the message throughout the global experience of performing bariatric surgery in patients with HIV. So in conclusion, bariatric surgery is safe, it's effective, it's durable over years to decades. We think, and you should think about bariatric surgery at the higher ends of the BMI. I would say the average patient in my clinic has a BMI of about 50, like 48 to 50. Those are the patients who need the surgery most. There's a strong improvement in mortality. And the reason is through reduction in cardiovascular and cancer events. We generally prefer sleeves over bypass for patients living with HIV, but in the literature, honestly, both bypass and sleeve patients tend to do very, very well who have HIV. And the only thing is we want to partner with you. So if you have a patient who's thinking about having the surgery, we do it, shoot me an email or I'll shoot you an email and we can talk about their ART afterwards. Most instances, we won't need to make any changes at all. And we actually have pharmacists who are well-versed in this who can support us in doing that. So with that, thank you very much. And I'll invite Diana back up and we can take questions.
Thank you both so much. Okay, I'm going to ask some questions from the audience and then I'll get to some online. Raise your hand if you have a question. I'm just going to wander and I'll ask one for Dr. Thiara. I'll say that, you know, there may be some limited published data in people living with HIV, but a lot of ongoing work and clinically using the GLP-1 agonist with great effect. I'm curious whether you know of any investigations or thought about using GLP-1 agonists for people living with HIV at a BMI under 30, whether there may be additional benefits conferred by that you mentioned, the secondary benefits like lipid lowering, cardiovascular event lowering, et cetera.
I think that, yeah, that's a very important question. So BMI is a very artificial, well, it's not very artificial. It's sort of this population health approach to representing body composition. And so we know that people with HIV do not necessarily have the same body composition as individuals who do not. And so I don't think BMI is the best surrogate for everybody. We also know that for certain ethnic groups as well. And so the issue is that the FDA has these criteria and insurance companies by and large do not want to pay for these drugs. So in order to get, even, you know, with our patients who are of Asian descent, we know that lower BMI targets are better for their cardiometabolic disease. But insurance companies, even if we send them all of those papers, if they don't want to cover it, they're not going to. But if there was a way to do body composition studies in individuals who have elevated risk for these other cardiometabolic diseases, and someone would fund giving people medications, I think it would be very interesting and powerful. And we probably would see something similar to what we see in patients of Asian populations, that BMI is closer to 25 have the same risk of cardiometabolic disease as non-Asian patients in higher BMIs. So all this is to say is yes, but the infrastructure of how to get these covered is so challenging and they're so expensive that we can't really get around it very well.
I could follow just on the surgical side. It's interesting, you know, as you know, patients with HIV have a lipodystrophy associated with ARTs. And one question I always had was, well, you know, when we do surgery and maybe when we do medicine, like, will it work as well, you know, or does the lipodystrophy persist despite the obesity intervention? Interesting, if you look at weight loss outcomes in patients with HIV, it's no different than patients who don't have HIV. So that lipodystrophy doesn't seem to affect their weight loss. You know, it doesn't override the effect of the surgery. So I wonder with medicine, maybe that we don't know enough, but it looks like with medicine, they get a pretty comparable result to patients without. So it doesn't seem to be a big factor.
So one comment just to make as this on is that we do have data in HIV with semaglutide in the slim liver study, which came out and were people living with MASLD who did in general have a high BMI, but not exclusively. And we saw really great metabolic effects in people living with HIV, not only on their liver disease, but also on blood sugar, you know, inflammatory markers, all the things you would expect at 1 milligram. So really not only did they lose weight, but great outcomes. And your point is well taken. It can be challenging to get, but I think really good data emerging to support use in HIV. And I think we're delighted to be using it in our practice and seeing how it works. I have 2 questions. One for each of you. One is that in the SELECT study, we saw that there was a 40% reduction in non-cardiovascular deaths, including a really intriguing signal about COVID. So it didn't reduce people's likelihood of getting COVID, but it reduced the risk of dying of COVID. And do you have an answer of why that might be?
Yeah, well, so sorry to back. I just want to be very clear that we are not concerned about using GLPs in people with HIV. I think that the data isn't there in terms of being able to compare it the way we have for surgery, but there's no concerns. So we should be using them, and I hope you all feel empowered to. And part of it, well, so in terms of your question, we don't exactly know, but we think that there are anti-inflammatory effects associated with GLPs. So there's a lot of studies going on looking at other inflammatory conditions like psoriasis and so on and so forth. And so the thought is, similarly with COVID, there probably wasn't the same level of inflammatory cascade that would make the sequelae of COVID, like pulmonary symptoms, as severe.
And Dr. Carter, just a provocative question. We just heard how great these drugs are and so transformative. What would your approach be? I mean, when I see someone who has really a high BMI, I think I'd reach for, a really effective GLP if I could get it and see what happened and then go to surgery. How have these drugs changed your thinking?
I think that's fine. I mean, people like to put us in competition, but I think it's really an adjunct. I mean, truthfully, my patients start at BMI of 50. I can maybe get them to 40. They're still severely obese, so they need a GLP-1, either in an adjuvant setting. So the analogy would be cancer. So early stage cancer, we treat with surgery or just one modality, and then more advanced stage we do surgery and chemo and maybe radiation. So I think similarly, I think the more obesity has set in, the more we need to do multimodal therapy. So for my patient population, I think they need both. You could ask the question, which one goes first? In a perfect world where GLP-1s were cheap, available, there weren't the pre-auth headaches, I'd say do GLP-1 for a year, see how much you get out of it. That'd be great. But in the real world, I think I would counsel my sister or someone to do surgery first, because we can get you surgery. You're going to get a huge bang out of that. It's not this scary thing. It's like a great intervention. And then I'm hoping that as a society, we work out the GLP-1s. Like, can we get them more available and cheaper and get our patients access?
Thank you both so much. We're over time. So any remaining questions, come down and ask our speakers or volunteer your emails if that's all right. Thank you again.